Jeremy's opening this session, this happy hour. This is the second happy hour of 2022. It's amazing that we're already into February. And I'm really delighted that we can partner with the National Academy for Social Prescribing and HACT for this particular session. Just by way of introduction, there's increasing interest amongst housing providers, commissioners and organisations on social prescription and various forms of collaborative approaches to supporting people better at home through care and support. It's something that the HousingLIN has championed through something we coined Collaborage. And I'm sure elements that we'll be hearing from all our presenters this afternoon will touch on those collaborative approaches to both individual care and support, as well as more community and neighbourhood placed support. Some of you will be aware that today the Institute for Fiscal Studies published a report on the care cap and what it really means, or what it really doesn't mean for people in terms of what their future care costs and support might look like. And with the recent Adult Social Care White Paper putting greater emphasis on the role of housing, and there's a key chapter, Chapter 4, which looks at ways that housing can be part of a more transformative approach to supporting older and disabled adults at home. We're really delighted that we've got a great cast this afternoon to share different insights, experiences and approaches to thinking around social prescription, both in terms of from an individual perspective, but also from a broader community or neighbourhood approach, as well as for people with particular long-term conditions. So without further ado, I'd very much just like to welcome Jeremy Hughes from the National Academy for Social Prescribing, just to say a few words before we pass on to Ingrid. And as you'll see from this programme, we've got about 10 minutes or so for each presenter, and then we'll have a Q&A session at the end. So please do post your questions in the Q&A box at the bottom of your screen. So Jeremy, over to you.
Great, thank you, Jeremy, and thank you to everybody who's joined today. The sheer number of people present today shows that this is the right thing to be talking about. And thank you from the National Academy for Social Prescribing to HousingLIN and HACT for hosting this event for us. When I designed the Accelerating Innovation Programme that Ingrid is going to talk about in a moment with James Sanderson at NASP and Catherine Johnson at RVS, we were very aware of the fact that social prescribing has tended to be seen as the preserve of the NHS and the preserve of the Department of Health. And the emphasis, quite rightly in one respect, is putting in place link workers in GP practices. But what we know, and I've worked my entire life in health and social care, including in the 1980s working with a number of social housing providers. In those days it was London and Quadrant, New Islington and Hackney and Hyde that I worked with. And what I know from then, and I've known through my career, is that people come into the health and care and support they need through trusted advisors and trusted collaborators. They don't necessarily go the route that the system wants them to go. And in many respects, it's the housing provider that is the first point of reference and the connection for the support that they can have to enable them to live well and to support all their health and well-being needs. And I think what's important today is that we recognise that in building this work stream that Ingrid will talk about as a subset of the Accelerating Innovation Programme to work with housing providers, and recognise that we're not just working with the Department of Health and with NHS England, but I think evidenced by the Levelling Up White Paper and the creation of the Task Force on Housing for Older People, we see that cross-government there's a recognition that we need to be working together. And indeed, local government has always worked very closely with voluntary organisations and the wider sectors to bring about the support that communities need. So without more ado, I'll hand back to Jeremy to start this webinar going, and look forward to joining with many of you in the workshop series that follows on.
Thanks, Jeremy, and Ingrid, I'm sure, will refer to those workshops in a moment as part of her presentation. She will be followed by Emma from Stonewater, who will follow by Janice, and then Richard, and no means least Sophie. So here's the agenda as a reminder. Do go onto the HousingLIN website or the links to follow it as we go through. But as you say, Jeremy, without further ado, over to Ingrid. Thanks for joining us.
Thank you very much. I'll just pull up my slides. And I just want to spend a couple of minutes telling you about social prescribing and the work of NASP. Some of this won't be new to many of you, so I'm just going to kind of just go through to make sure that you kind of have the up-to-date information from NASP's point of view. So what is social prescribing? It's a big question, but one that I think there's a risk that we get too caught up in. So definitions obviously are important, but I don't think we should get stuck on them, because the social housing sector has been doing social prescribing for a generation or more. It's just that you haven't spoken about it in those terms. So from a very, very basic point of view, social prescribing is a way to connect people to practical and emotional support in their communities and beyond. How we do that, who does that, that's still something that I think we're all working out. We're all coming up with different models of how social prescribing could work, should work, works best, and we're still finding evidence about the different ways that social prescribing is able to connect people to that emotional and practical support. But at the heart of social prescribing is a conversation and a relationship. It's about two people, maybe a professional, maybe a friend or a neighbour, maybe someone from a housing association or a charity, having a conversation with an individual where they can say what matters to you. And that person can say, these are the things that matter to me, and these are the things that I want to create a plan around to support my health and well-being. And all of the social determinants that go into somebody's health outcomes. So that relationship is at the heart of any kind of social prescribing, and that question, what matters to me, is really the most important one that we need to be focusing on. When it comes to the NHS, to what we might think of as kind of the current form of social prescribing, well, the NHS long-term plan aims to have 4,000 link workers in place by 2024. We're about halfway through on that target. And by 2024, the aim is to have 900,000 people having been referred through social prescribing. So that's, I think both of those will be blown out of the water by 2024. But I think it's important to understand that social prescribing is now at the heart of personalised care agendas, but that it's also part of much broader government agendas and much broader community action across the country. So in terms of government, it's part of DEFRA's plans, it's part of the food strategy, it was in the Levelling Up paper. So, it's not just about health and social care. And who is social prescribing good for? Well, I would say it's good for all of us, but of course I would say that. It's particularly good for people who have one or more long-term health conditions or who have complex social needs, because it's holistic, because it's based on the person and it's based on personal conversations. It can take into account all the aspects of someone's lives that they'd like support with, rather than just treating, diagnosis by diagnosis the way a health or a health deficit approach might do. It's also particularly good for people who want or could do with mental health support, especially preventative mental health support, and also for people who are lonely or isolated. So it can address a number of different aspects of people's lives, but those we have found the evidence shows that it's particularly good for. And why do we need social prescribing? As much as 90% of our health outcomes are not directly related to healthcare, which means that they are related to all the social determinants and all the social aspects of our lives which impact on our health and well-being. And we believe that investing in those social determinants is the only way to achieve lasting change, because it's something you can build up in individuals, in communities, in society over time in order to improve health outcomes and reduce health inequalities. We know that as many as 1 in 5 GP visits are about non-clinical needs. So we also know that GPs are good gatekeepers for those people who might go somewhere for support that is not clinical. That's why the NHS is so invested in link workers. But we also know that people are unique and complex, and therefore we need a person-centred approach. And person-centred approaches are now at the heart of the NHS's plans, but they've all for a very long time been at the heart of the voluntary sector's work, and increasingly, of course, at the heart of housing and other sectors. We know that everyone has a part to play. This is a society-wide transformation, and social prescribing is a way of bringing everyone's contributions together. Very briefly, there are different ways of linking to activities and support. People might reach those activities and support independently. You might hear this described as self-referral, or they might find activities and support through their friends, neighbours, or through community groups. And then there are people who need specialist support from a link worker. And I think housing sits somewhere in between, and the edges are fuzzy, partly because the topic is fuzzy. NASP works across the social prescribing movement. The two programs that you'll know best are the Thriving Communities program, which works with hyperlocal organisations, and hopefully after this, our Accelerating Innovation program, which works with national voluntary organisations. But there's a lot that we do to celebrate and evidence the work of social prescribing. And the Accelerating Innovation program brings together those national voluntary organisations to learn from each other, to form new partnerships and develop new ideas. And we have a community of practice that comes together to do that. Our community of practice is around 80 organisations at the moment. And within those organisations, we're putting together working groups who can tackle a particular challenge or opportunity, either in a sector or an outcome or in a population group. And this is where the work on housing is happening. And so I'd urge you all to, if you're interested, to join our working group on housing. After this webinar, we are building a series of, at the moment, 3 workshops to bring this working group together around areas of innovation in social prescribing and housing. So the first one is on March the 17th in the morning, and it's about how to build social prescribing into your team of staff and volunteers. So Sally will put the link in the chat for you to register, and I look forward to seeing you there. Thank you, Jeremy.
Ingrid, thank you very much. And in fact, what's really interesting, we've had a question already come in, and we'll pick up all the questions later, but that point that you really kicked off with by saying many people working within housing will not even realise that they are actually undertaking and have been undertaking social prescribing. I think you said for generations. I think that's very apt. An organisation I know who's got this very much at their heart, it follows next. So Emma, I'm really pleased that you've been able to join us, and I know you've done a lot of work behind the scenes, and thanks very much for coming to share what you're up to across the organisation. So over to you.
Thank you, Jeremy, and thanks to HousingLIN for giving me the opportunity to come and talk today about our Communities Can project. So I'm just going to share my screen. Okay, and I'll get started. So Stonewater is a housing association that manages 32.5 homes in England for over 70,000 customers. And this includes affordable properties for general rent, shared ownership and sale, alongside specialist accommodations such as retirement and supported living schemes for older and younger people, domestic abuse refuges, and a dedicated LGBTQ+ safe space. We already had an ongoing ambitious change programme with a 9 million refurbishment programme that's enabled investment and improvement works in our retirement living stock. And it's providing modern, functional, high quality designs that we were hoping that was going to reposition Stonewater's retirement living. And then through 21-22, we turned our attention to enabling communities, and we aim to explore issues of community connections, cohesion and capacity, and the part that we can and do play in localities in which we operate. We've taken some time to listen to what mattered to our customers, particularly during the COVID pandemic. And we wanted to transform our relationships with customers and the communities, and understanding a role that we play in enabling a more connected recovery. We have the aim of thinking about the well-being of our customers, their personal assets and strengths, and the steps that Stonewater could take to maximise the positive impact of these. We felt we had a crucial role to play in creating the conditions in which connections and contributions and cohesion could thrive. So we've worked alongside Community Catalyst. Community Catalyst is a social enterprise who work in partnership across the UK to try and make sure that people who need support to live their lives can be part of a strong, inclusive communities. And we set out to develop the people, connections and community elements of our Stonewater Change programme. The plan would start work in a targeted area to help identify work within the organisation that's already working really well. And then we'd build from there, co-creating tools and approaches and strong exemplars that could be rolled out across the whole of our organisation. And our approach was, as it says on the slide, to learn from Community Catalyst approach, connect and engage across 3 locations, listen and learn and empower and change through better conversations, start with what's strong and matters, discover what works well, support staff and stakeholders with practical tools to map assets, and share stories that inspired others to take a community-centred approach. So through a test and learn approach in our localities, we've been engaging with local residents, listening, learning and doing, and we hope that this project would support Stonewater staff and customers to have better conversations, co-create solutions, and together create situations in which more people felt connected. Our ambition for the partnership was that a shift would take place in the way we think and act as Stonewater staff, and through the resulting dialogue and relationships with customers, we play a more enabling and empowering role in order to improve lives. So what approach did we take? Well, our colleagues started to map community groups and assets in each of the localities, but essentially everything started with a conversation. Our Stonewater colleagues started reaching out to our customers and community groups across the 3 localities, using various forms of communication, whether that be a telephone conversation, a chance meeting in the street, or conversations that we started through our newsletters. And we just started those conversations with these sets of simple questions that you'll see on your screen now. One of the early connections that we made was with a customer in Copley Mill Village in Copley in Halifax. Copley Mill is a small village. It's got 1 road in and it's got 1 road out. And during our conversations with our customer, we established very early on, as you'll see in the photograph, that the bus stop had no seating area. And it was putting off customers using the bus because they'd got no safe waiting area. They weren't able to access any seating whilst they waited for the bus. So we contacted the owners of the bus stop and confirmed what we suspected was that the footpath was too narrow to put any seating in. But what we also realised is that Stonewater actually owned the land behind, and you'll see in that third photograph a picture with a wall. And so what we've been doing is gaining quotes to actually look at taking the wall out and putting a seating area in, so that we can enable people to just sit down or engage in conversations, or simply have somewhere to sit down when they catch the bus. Next came our gathering in September. I know this slide looks very busy, and I have got this as a handout to go out to everybody afterwards. So in September last year, we held our gathering with over 40 people from Putney in Bedfordshire, Copley in Halifax, and Fremantle in Southampton. And we all gathered together online and face-to-face to celebrate their local areas and discuss what could be even better. At the gathering, we heard from each local area and what they've been up to, and the conversations that had been taking place between Stonewater colleagues and all of our customers. These conversations and discoveries were creatively captured throughout the event by Anna, a graphic designer, who drew the representations of the conversations, which is what we're looking at on the slide now. Highlights of the gathering included a passionate contribution from Mary in Putney, who shared her deep knowledge about the local area and the wonderful activities that she's leading and involved in. Now, Mary articulates this so much better than I can, and so I'm hoping that Jerome's going to be able to share the clip with us now.
Thank you, Mary, for coming along, and thank you for spending some time to talk to me about your Bedford community.
Community spirit is very important because we've moved away where families played a very large role in looking after grandma, looking after granddad. There's more and more going on in the area. Our local church hall, which is a community centre, it's a Christian community centre, nobody worries what religion you are, what you believe in or anything. You are welcome in that church hall. And on a Thursday morning we have Project 41 because our postcode is MK41. My daughter often gives me black bags full of things to take to the local charity shop. And I'm thinking, there's children on my own estate who really love these clothes. So on a Thursday morning between 10 and 12, I started a swap shop. And I started by asking my friends and my daughter's friends for their children's outgoing clothes, what they normally would just pass on. Mums can bring outgrown children's clothing, swap them for a bigger size or whatever they need. By that, everybody is sharing. If you are on universal credit or whatever, even if you're just a young mum, money's tight. There's no money involved in my swap shop, just clothes.
Thank you. Sorry, let me just get back where we were. And Mary's story isn't unique. We've got various swap shops that are sort of up and around within Stonewater. But what's different about Mary is that it's not just within a retirement living scheme, it's for the wider community. We also had the privilege of hearing from Bob, an artist living in Copley Mill House, a retirement living scheme, who, as a result of conversations, will now display his artwork that's been commissioned by Stonewater in a newly refurbished Copley Mill House. Following the gathering, we've heard from Trish, a published author from Copley Mill, who was connected with a young woman from another locality who's an unpublished author, and she's now mentoring her through the process virtually. And we've heard how another customer from Putney has started to share IT knowledge and skills to another customer from the local community. They now meet weekly in one of our schemes to share a cup of tea and IT skills. And it's been wonderful to see people coming together, forming new connections and coming up with ideas how they can make their communities even better. And I flipped my slide very quickly, so you've seen my next slide already. But just to say, I wanted to pose the question: would your organisations, housing associations out there, be ready? Because we had a number of challenges or questions that we had to overcome as part of this project. And one of them was, would our operating structure hinder us? How would we have local conversations when we didn't have a local presence? So we'd recently reimagined our customer experience teams, and in some instances, the local presence and knowledge just wasn't there. How would we connect people in a virtual world? How would we speak with communities in place? And we had to adopt our resources. Some customers joined us from their own devices, and others in facilitated sessions in communal rooms with Stonewater colleagues. And managing board expectations. Our board wanted measurable outcomes, and what we were having were customer conversations and hearing great stories of work that's going on in our communities. And so we had to juggle how we communicated back what we were actually achieving as part of this project. And accepting that we weren't the experts in these communities, and we had to be prepared to listen, let the community tell us what they wanted. And we were on our own journey of discovery. And I've said there, it sounds cheesy, but we really haven't reached where we wanted to get yet. And so in summary, I would say our conversations are just beginning. Community catalysts are starting to gather the insights for us around what we've heard and what's been represented across different stakeholder groups. And we're starting to draw on the insights and create an action plan for change. We know from our own observations that during this project, we've seen connections made across localities that may never have been spoken to each other before if it wasn't for this virtual world. And we've connected our own Stonewater organisation communities, colleagues working together on a shared interest that might never have worked together before. So Stonewater is committed to continuing to explore how it can make a positive difference by getting alongside local people, working together and building on each other's strengths and contributions. We will have a set of principles rather than a prescriptive framework for our organisation to take forward. But what we know is that it's built with the customers and their communities. Thank you.
Emma, thank you very much. A real succinct presentation. And you probably haven't had a chance to look at the chat box, but a lot of people have sort of real touched the nerve, either because they've actually grew up in some of the locations that you've described, but also sharing some examples of their own practice, some of the evidence that's available out there, demonstrate the impact that's being made in their local communities. And so some of those issues around measuring success, the impact, both the social impact, as well as the sort of the financial impact, I'm sure those will be conversations we'll have in the Q&A later. We're going to quickly move on to Janice. Janice, thank you very much for joining us, and I think this is the first time you've been part of the Housing LIN's Happy Hour, and
Yes.
You're going to talk about the neighbourhood coaching approach that Bromford have developed, and you're one of their neighbourhood coaches, so really
Yes.
looking forward to hearing from a first-hand experience.
Thank you. Well, good afternoon, everyone, and thank you for having me. Having the time to build connections with people means that my role has changed from one where customers used to run away when I walked down the street to trusting me with personal information. As has been said, my name is Janice Small and I'm a neighbourhood coach with the Staffs and Marches team, and I cover North Herefordshire. When I first worked in housing, I had a patch size of over 500 houses and customers, and it was largely a reactive role. Only dealt with bad behaviour. Customers didn't trust me and avoided me. And really, I never met most of them. I remember visiting a part of my patch for the first time and watched customers run from their garden gates to indoors, closing the front door firmly behind them and pretending they weren't in when I knocked. And a child asking me if I was the housing lady and told me his mum said I only ever visited to tell them off. Well, in 2016, Bromford moved to a neighbourhood coaching approach. We were given smaller patch sizes. We went from being called housing managers to neighbourhood coaches, and we were given permission to spend more time in our area and community. I got to build relationships, got to know customers' strengths, aspirations, build trust, and ultimately watch them thrive. Housing metrics like arrears and ASB are much better, but success is more about everything else that we do. Don't get me wrong, it wasn't and isn't all pink and fluffy. Building those relationships is an ongoing task, and some people will not buy into the coaching approach. People don't just trust a stranger overnight and open up to them. I needed to prove myself to my customers, to convince them to believe in me by having open, honest and coaching conversations, such as asking questions like what barriers are in place to stop a customer succeeding or paying rent? How does it make them feel to have arrears? What would their future look like if they could achieve their aspirations? What do they want their future to look like? What is stopping them from having a conversation with their neighbour about the dog that barks or music a little too loud? And over a period of months, via lots of visits, often unsuccessful, but carrying on until the front doors opened to me and I could introduce myself and ask my customers how they were doing and start to build the relationship. I've also built up a lot of community connections, such as with the neighbourhood policing team, social care, food banks, charities and voluntary services, to name but a few. And I've listened to what my customers want out of life and coached them using stepping stones to achieve their goals. It could be just to live in a property that's clean and tidy and get on with their neighbours, or it could be using their homes as a stepping stone to buying a property or building relationships with other customers. And one such instance happened during lockdown when some of my customers took it upon themselves to check on the more vulnerable, and they held coffee mornings out on their driveways, chatting for an hour, which helped with isolation and poor mental health. This has continued and includes more customers and has improved relationships between customers who never used to speak to each other, and they all say they feel less isolated and lonely now. I've coached vulnerable customers to engage with local police to feel more supported and less frightened. And I've coached private residents and customers to join forces to combat low-level ASB by joining a neighbourhood watch scheme and rewarding them with a scheme improvement to brighten the area up, and vulnerable and lonely customers to join groups within the community, such as coffee mornings, lunchtime clubs, and improve their literacy and IT skills, which helps with their mental health, loneliness and isolation. I take you to one day I visited a customer to talk about their untidy garden, but because I had the time, I was able to start my conversation with asking how they were. I could see the look of amazement on my customer's face and disbelief that I might be interested in them personally. They volunteered the information about their garden and told me that they had a degenerative disease where they'd gone from being a fully functioning adult with a full-time job, wide circle of friends and activities, to being unable to go out, work, much less look after their home. And due to my community connections, I was able to involve local social care who assessed the customer and agreed to put in a care package. I know this visit sounds so easy, but it had taken me months to finally sort of encourage that customer to engage with me. And I gradually went from the endless unsuccessful visits to visits talking about our customers, not the problem initially, but finding out their strengths, their aspirations and interests, as well as any challenges they may face. And our starting well visits, which are carried out when we have a new customer on board, are sort of quite matter of fact now. We involve more about the customer, mainly talking about what they want to achieve in life and how their home may help them to do this, such as a new customer who just recently divorced her abusive husband and was left with 2 young children. Her aspiration was to become a teacher, but she didn't really know how to do this. And I was able to connect her to a local work coach who talked her through how she could achieve this, a local children's centre to offer childcare. And together we looked at grants and benefits that she could access to make her journey affordable. It was a really difficult journey for her, balancing part-time work, university and mothering her children, but she achieved it and is now a qualified teacher. I've been able to signpost lonely, vulnerable, young, new single mums to Children's Centre to help them build friendships and get rid of that loneliness that they might be feeling. And in actual fact, some of the communal teams that we collaborate with, such as the local policing teams and social care teams, voluntary groups, they now come to me if they have a concern about a customer of mine, or if they want to ask me something about the community, or want one of my customers to volunteer somewhere. There is a story of a young girl on a starter tenancy with she was a heroin addict, and if we had been in the old role of a housing manager, she would never have succeeded in managing her tenancy. And it was because of our neighbourhood coaching approach that I was able to support her and coach her with an open and honest conversation. And the result was that she was so lonely because she'd moved areas to get away from the drugs, etc., was really sort of getting involved in the wrong crowd. And I was able to connect her with a local group where she could meet new friends and build new strengths and skills. We've also coached our customers to report repairs for themselves, use our online services and manage their money in debt. We communicate with their to help them to communicate with their neighbours and other residents and take pride in their local community and themselves, and encouraging them and coaching them to be the best they want to be. Romford's purpose is to invest in homes and relationships so people can thrive. And as neighbourhood coaches, we deliver this by developing open and honest relationships with each of our customers. We meet people wherever they are, and by coaching and connecting, we help them to get to where they want to be. We build on people's strengths and know that when they succeed, we succeed. And we always remember that at the heart of the relationship is a home that is safe, warm and affordable. Thank you.
Janice, that was great. And I'm sure everybody listening will see how you've really turned housing management on its head. That sort of relationship about building trust and sort of building on from what Emma was talking about, that sort of creating communities, I think is really important. And I noted in some of the chat comments, people saying, how much it's not just about looking at individual patients from a health perspective, it's looking at the lives and the well-being of people and how they relate, both in terms of the person-centeredness that Ingrid referred to, but also that wider community relationships. And I'm sure we'll come on to that in the conversation later. So thank you very much for your contribution. That's really helpful. We're going to turn to Richard Harrell now. Richard's going to give you a slightly different take. Richard, for many years, has worked in the built environment and construction industry, and has recently worked very closely in sort of setting up and working closely around cancer communities. So, Richard, over to you.
Thank you very much, Jeremy. It's great to be here. I'm a bit of an outlier here because I'm going to talk about a slightly different community and a slightly different take on social prescribing. And I'm going to talk mainly about the construction community. And let me just share my screen and we'll get rolling. But I'm fascinated by social prescribing because I set this charity up, We Build the Future, primarily to try and address health inequalities that I saw across the construction sector. As we've gone on the journey of establishing this charity and starting to run projects and do some thought leadership and thinking, what's become very clear is that the kind of broad health and well-being picture for too many people in the industry is difficult. I'm going to give you some background. Some of it's cancer specific, but I'm going to talk a bit more about the demographic of the industry and why we think there are such serious health inequalities. I'm going to talk about a pilot project that we did working with frontline GPs in North London to get access to people working in the construction industry. And I'm going to talk about where we go next in terms of creating pathways through to access advice and support. And I think this is a community that is really ripe for social prescribing because the range of issues that contribute to poor mental health and poor physical health in the sector are becoming quite manifest and obvious. So We Build the Future, we were established to raise funds to improve cancer research, improve support and advice for people in the construction and built environment industries who are affected by cancer, whether that's directly or looking after someone or having to deal with perhaps an employee who has a diagnosis or a problem, and also more broadly to promote health and well-being as a way of reducing the incidence of cancer. And of course, those kind of health and well-being benefits spread across a much wider range of health conditions. Very briefly, these are the kind of realities of cancer. Unfortunately, 1 in 2 people will be diagnosed with cancer at some stage during their lifetime. And I set this charity up after my father died of bladder cancer, primarily because I looked around our industry and realized that there was a dearth of support. We've become much better at kind of health and safety on the construction site, but in terms of the way that we care for our people more broadly, with the support that we offer to them, it's really absent. And I felt this was something that we could start to address. We think that there are around 150,000 people who will be dealing with cancer or in remission in the construction workforce at the moment, and built environment workforce, with around 12,000 diagnoses each year. So these are big numbers. These are big proportions of our people who are having to face up to dealing with cancer, and it is still the biggest killer amongst men. And critically, breast cancer is the biggest killer of women, 24 to 49. There's a lot that can be done. 4 out of 10 cancer cases are preventable. So actually getting advice and support and working with people and the industry to look at preventative measures is important. Smoking in the construction sector is still around about twice the national average. And 44% of occupational skin cancer diagnoses are people working in the construction sector. Prevention can do a lot to help reduce incidences of cancer, and we're not really doing enough. And of course, construction actually has an absolutely appalling, a shameful legacy, really, in terms of the way that the actual work and a history of not dealing with site safety as well as we do now has affected people. So 56% of all occupational cancer registrations in men are attributable to working in the construction industry. 40% of all occupational cancer deaths are in the construction sector, and that means that for every construction worker that's killed on a site, 100 workers have been affected or killed by occupational cancer. So there is an absolutely enormous problem that we don't talk about, and there's an enormous number of people in the sector. And I want to think of the construction industry and the built environment industries as a community in this respect that need more assistance. early diagnosis is critical, and getting people into contact with care is difficult. So key on this slide is the kind of demographic issues that the sector faces. So 92% of construction firms have 7 or fewer employees. They don't have support networks. They don't have the time to actually structure the way that they look after their employees when they're at health problems. 42% of workers are self-employed. They don't want to talk about health problems in case they don't get the phone call for the next job. They don't want to miss a day's work because they don't have any benefits or pay. The construction sector is overwhelmingly men or male, and men are notoriously bad at actually seeking support and getting access. So 32% less likely than women to consult medical services, and it's more like 42% in the 16 to 60 age group. So this is a group with some really serious problems structurally and in terms of the support they can access. We are all, I think, also becoming aware of the much wider kind of health problems that we have in the industry, and mental health is an absolute leading indicator, I think, of the general state of health and well-being. So these figures on the right are from a survey done by the CIOB. 95% experience poor concentration, 87% of people surveyed had anxiety, and 26% had suicidal thoughts in the previous 12 months. And it's a really scary indictment of how stressed this community is. And the key factors that drive mental health are also really serious factors in terms of physical health and well-being as well, and the ability of people to actually access healthcare is severely limited by hours, cultures, lengthy commutes, time away from family, pressure to complete work on time within budgets, and a macho culture that just doesn't really support people to access the care that they need. There's a huge cost associated with that. We think it might be £4 or £5 billion that it's associated with non-occupational health issues compared to the occupational health issues. And what we're really interested in, and we've started to work on, is that we have trustees a frontline GP, and she's changed our view of where the biggest wins are at the moment in helping this community in this sector. So we think that creating a culture that actually encourages people and supports people to get the support they need is critical. There needs to be a much extended focus beyond occupational health, and we need to actually break down the barriers to people accessing healthcare. So to do that, we set up a pilot project on the King's Cross development, where we actually took the healthcare workers onto the building site and promoted site surgeries to consult with staff, and started to get feedback from the construction workers as to what worked and what didn't. There were a series of 16 clinics over 6 months, and they saw just under 100 patients. And what was clear was that there was a need for this community to access healthcare and support in a medical sense, for sure. And most of the conditions, in fact 99% of conditions that people came in with, were chronic conditions that were absolutely suited to being addressed through the kind of primary healthcare system, that it wasn't a substitution for going to the A&E department, and a number of really serious conditions were picked up. And the overall feedback was that there's an enormous appetite within the industry to actually access and engage with this health and care and support networks in a way that they just feel excluded from doing at the moment. And the biggest barriers are kind of actually being able to access and engage with their services. There are some language barriers, but also this culture where seeking help or admitting that you've got a problem is seen as a really negative thing to present to your employer or co-workers. So where do we go next with this? Well, this is what I'm excited about. COVID-19 is clearly a terrible pandemic event, but it has changed the way that we are able to engage and consult with our support services. The NHS, I know, has work streams on actually looking to innovate, and we're now working, talking to NHS North London about how we can actually act as a bridge to promote the use of e-consultation to actually get this industry on a level footing in terms of consultation with the rest of the industry. And we're doing that through something called Project Open Door, which is really it's a cultural push to make employers and others promote access to healthcare and to social prescribing, which I think is absolutely ideal for the complex problems that a lot of people in the industry have. It's going to be a big push on awareness and profile raising, and it's really exciting to be able to start to kind of develop the data on this and see how much difference we can make within this community. It's a different community within the housing sector, but it's still a really important one. So thank you for listening. I hope that's been of interest.
Richard, it certainly has. Again, some really excellent presentation and some really great feedback already in the chat box and how it links into other long-term conditions as well. But I know you've put the spotlight in your work in cancer, but I look forward to coming back to that. As Sally has just reminded, please do leave your questions in the Q&A box. I know one or two of you snuck them into the chat box. If you have, please cut and paste them into the Q&A box. And our final presenter is Dr. Sophie Archer. We're going to sort of open this out a bit, and the beauty about her coming last is she can weave in a number of different strands from her recent book, Creating Spaces for an Ageing Society. So Sophie, over to you.
Thank you very much. Thank you, Jeremy, and to the rest of the team for inviting me to speak at this event. I'm really delighted to. And yeah, so hopefully me coming at the end will help, as Jeremy said, kind of pick up on some of the comments from the other speakers. And I think the thing that we've mainly seen from the talks is the importance of relationships and having conversations. And so what I'd like to reflect on in my presentation is the fact that those relationships and those conversations don't occur overnight, and that also they don't occur in thin air either. So what I'd like us to encourage us to think about in this presentation is what are the different neighbourhood and social conditions that are needed to support social prescribing, to provide the foundations for social prescribing to happen? And then what is the role of social infrastructure in helping us with this? So where are these conversations and where are these interactions and social relationships? What are the actual physical spaces they're being developed in? So that's what I'm going to be talking a little bit about this afternoon. And as Jeremy said, this is coming from my book, Creating Spaces for an Ageing Society, the Role of Critical Social Infrastructure. And in the book, I'm just defining social infrastructure quite broadly as any physical space and place in neighbourhoods where we can have social interactions and where we can develop social connections. And we've heard a couple of examples of those different types of spaces already. So in the book, I was particularly interested in how social infrastructure can support older people in their communities. So it's a review of existing academic and policy and grey literature. And throughout the book, I've kind of reviewed this literature on different types of social infrastructure spaces and thought about how those spaces can support older people to develop social connections in their communities and how those spaces can develop age-friendly places. But hopefully there's kind of wider learning in the book as well, and in some of the literature for kind of wider community development, cohesion work and social prescribing as well. So as I've mentioned, we've already kind of heard about some of the kind of physical spaces that are important to social prescribing work, and some of the spaces that might come to mind are places like community centres we've heard about a lot, maybe libraries, leisure spaces or spaces where kind of leisure and sports activity take place, spaces of volunteering where people have opportunities to come together in volunteering work. And all these spaces are hugely important for social prescribing, and social prescribing wouldn't be able to exist without those spaces. These are all parts of social infrastructure that bring people together and are very good at organising activity. They bring people together around some sort of organised activity, some sort of shared interest, shared value, shared commitment, shared purpose, etc. So these are really important parts of our social infrastructure to think about supporting social prescribing work. But what I'd like to think about a bit more today is the other types of social spaces, the other kind of social infrastructure that support these spaces and that support social prescribing work. So the types of social infrastructure or neighbourhood spaces that are maybe below the radar slightly and we don't immediately think about as social spaces. So I'm thinking about how social infrastructure can support social prescribing. Some of the stuff that came from my book and the kind of arguments I want to make are firstly the importance and the strength of weak ties. So we've talked a lot today about the importance of social connections and social relationships, but I really want us to kind of think about what types of social relationships we're thinking about here. And are we talking about weak ties such as acquaintances, or kind of strong ties and friendships and social bonds that kind of require more obligation and more responsibility? So thinking about the different types of social relationships I think is really important. And also the importance of bridging social capital, so the capital that kind of allows us to connect to people outside of our usual circles or kind of into other different types of networks. I'll say a little bit more about that in a second. And also the importance of everyday neighbourhood spaces, everyday social infrastructure spaces. Again, those spaces kind of maybe outside of the traditional remit of social prescribing, the spaces that aren't particularly seen as social spaces, but nonetheless have an important role to play in developing social connections in our communities. So I mentioned a bit about the need to think about different types of social relationships when we're thinking about the importance of these things in communities. And I guess this is just a bit of the science bit. I'm sure many of you will be familiar with the concept of social capital. So when I was going through the existing literature for my book, when I was reviewing it, I was constantly thinking in mind, what types of social relationships are being developed here? What kind of social capital is being developed in these different types of spaces? And so there's different ways of thinking about social relationships and how we can describe the different work that they do. So very simply, we can think about bonding social capital, which is groups of people that share something in common that bonds them together. So maybe people of the same religious background, for example, that would bring them together, albeit there'll be differences within that group, of course. But bonding capital is when we kind of bring people together around a common bond, something that binds them together. Whereas bridging capital is about kind of connections outside your usual social circle. So connecting into other networks, which is known as a huge important part of what social prescribing does, is connecting people into social circles and networks and support outside of their remit that they haven't been able to access before, perhaps. And then we can think about the different kind of strength or relative weakness of social ties and social relationships. So strong ties will be characterized as a friendship, where there's some sort of ongoing maintenance to kind of continue that relationship. Whereas weak ties is maybe more acquaintances. So people you might know by name, you might recognize them, but you maybe wouldn't meet them outside at a particular social event, for example. So these kind of weak ties or kind of fleeting interactions, I want to argue, are particularly important as well. I guess what I want to suggest then, kind of looking at the work that I've done on social infrastructure and how that can support social prescribing, if we think about social prescribing activity as a kind of tip of the iceberg or the kind of the end point, I wanted to argue that kind of this work obviously very much heavily relies on formal and informal networks, as we've already heard from many of the presentations this afternoon. Those informal and formal networks rely on social capital and social relationships. Those social relationships and social capital rely on some form of social interaction, and that interaction has to happen somewhere. And that depends on having the spaces and places in our communities where people can have social interactions, come into contact with each other and have those conversations, perhaps, or the beginning of those conversations, which we've heard are so important for social prescribing work. So I just want to take you through a few pieces of the research that I reviewed for the book to kind of pull out some of the things that I think are important about them in terms of how they might be able to, the learnings might be able to support arguments around social prescribing. So a big chunk of the book that the research in the book that I looked at was around commercial venues, particularly things like cafes and restaurants, hospitality spaces, pubs as well can be included in that. So I reviewed that research and I was thinking about how are older people particularly using these social spaces and what types of social connections are they developing within these spaces. And there was a really interesting paper by Chang who looked at older Japanese American adults living in Honolulu and how a particular group of these older individuals were kind of meeting in a particular fast food restaurant in their neighborhood. And he talked about the kind of social interactions that were occurring here. And it was quite interesting, the fact that these individuals weren't necessarily going together, they were all going at the same time and would sort of happen to see each other there. This wasn't kind of a pre-arranged, kind of organized or kind of formalized social activity. But people would drop in through various times throughout the day and became familiar with each other to an extent. So there was lots of kind of informal interactions occurring between the older participant, the older customers and themselves, and also some of the staff members as well. And what was really important for these older people when they were interviewed about the social interactions was that there was no expectation to go along to this fast food restaurant and have particular social interactions or to be involved in particular social activity. They just enjoyed being around each other and would maybe have conversations with each other, maybe not. It was very kind of free and easy, very informal. There was no obligations to interact. There was no obligations on that particular types of social interaction. And Goffman calls this civil inattention, which I think is a really helpful phrase of kind of the importance sometimes of just being around other people and being in a social space without any obligation to participate in that sociality itself. And this was also found to be very important in terms of relationships of service. So the relationships that these older people had with staff within the fast food restaurant as well, in terms of making them feel comfortable in the space, and allowing them to spend as much time there as they felt appropriate, and not kind of orchestrating it too much as well. So I think there's an importance here in kind of the kind of unassuming spaces of particular chain food restaurants. And this is something that surprised me in the literature around how some groups of older people will use hospitality spaces, and sometimes a preference for chain restaurants or chain cafes as opposed to independent places. Excuse me. And this was something to do with the need to have a space that they could make their own, and they felt that there wasn't any particular norms that they had to follow. They were able to use the space the way they wanted to. So a slightly different example then of another type of social infrastructure space that was found to be particularly important. It was banks and post offices. So they're not particularly glamorous part of our high street, and they're certainly not a space that we would consider as a social space. But they were still found in the research for older people in particular to be quite important social spaces, even if those interactions and spaces were very fleeting, very informal, and sometimes even non-verbal. So in a study by Citizens Advice in 2017, they found that 65% of those aged over 65 saw the post office as either very or extremely important to them, ranking it the second most important community facility after pubs, banks, and community centres. So this is a space where people would use on a regular basis and maybe see familiar faces, or just, again, this kind of civil inattention of being around other people that was found to be really important. And again, banks have been found to be really important for combating social isolation, as well as preventing fraud, so the kind of wider social benefits as well. So I want to characterize these spaces as kind of passing places where we might have fleeting interactions with other people. We don't necessarily go to have social interactions there, but those fleeting interactions can be just as important. And obviously the kind of wider debate here is there's an inequality of access to these type of spaces, and we've seen the closure of banks and post offices in some of the most economically disadvantaged areas in the UK, for sure. And then a final example which I wanted to include, because I think it relates quite nicely to social prescribing and kind of social determinants of health argument, was a paper by Lin who looked at hairdressers and barbers and their role in health promotion activities. And there was very little actually literature around hairdressers and barbers as social spaces for older people, but this kind of area of literature I found particularly interesting. So a lot of health promotion work was done in these spaces, particularly because there were spaces where you could reach people that maybe weren't accessing other services. And we've heard in presentations earlier this afternoon about there's certain groups of individuals that for various reasons either cannot or are resistant to accessing services through a traditional route perhaps. So a lot of outreach work will kind of use this kind of informal social spaces outside of maybe the community and voluntary sector or the public sector to access communities or individuals that might not be accessing services elsewhere. So hairdressers and barbers are found to be really important because they do have a social atmosphere. They're also very unassuming and everyday in nature. People do use them on a regular basis to varying degrees. And there's a particular importance here about the really trusting relationship that can be developed between customers and staff, and particularly in these spaces as well. So I think some of the things that kind of tie those spaces together, those different social infrastructure spaces together, is that they're very everyday, kind of mundane areas of social infrastructure. They're used by a diversity of people, so everybody uses those spaces to some degree at some point, or at least they're open to, whereas maybe some other kind of organized activity spaces might not be as open to everyone on a regular basis. They're very everyday and unassuming spaces, part of our kind of normal routines in our communities. And they support a range of social interactions, both verbal and non-verbal. And a lot of the literature is quite clear about it doesn't always have to be a conversation. The conversations don't happen on their own. Sometimes they happen as a result of weeks or months of non-verbal communication and kind of recognizing people or nods of acknowledgement, etc. And they all provide the opportunity to develop these weak ties of association, these kind of fleeting interactions. So if we just go back to the kind of pyramid that I presented at the beginning of the presentation in terms of how social infrastructure can support social prescribing, I think it's really helpful for us to think about the types of social connections that are important and the types of spaces where these connections might be developed, and to kind of widen our thinking to the kind of social infrastructure spaces that might be important in social prescribing work. So just to summarise then, the importance of bridging social capital been proven very important for social prescribing and kind of networking silos and creating bridges into other social worlds, connecting people into services, supports and opportunities that they may not have been on their radar before. Fleeting interaction and weak ties, I think, need to be taken as seriously as more involved social actions, and stronger ties. We shouldn't underestimate their importance. And we need to be thinking about an ecosystem of social infrastructure to support the different types of social capital. And I think this kind of clearly points to the importance of these everyday passing places and supporting the work that social prescribing is able to do. So thank you very much for your time. I'm happy to take any questions.
Sophie, thanks very much. And I think you skillfully wove all those things together, providing also, I think for me, a very helpful theoretical framework, but also sort of reinforcing the importance of those bumping places, sort of whether it's in the community, in community hubs. And I know also some of the work in Manchester is supported by the Centre for Ageing Better, who are very keen to understand that in relation to age-friendly retail offer as well, thinking about the lighting, about the seating arrangements, the signage, and etc., and all those sort of things which can help people better interact. I'm conscious we've been joined by Andrew Van Doorn from HACT. Very good to see you, Drew. I'm just wondering, before we go into the Q&A, do you have any overarching thoughts that you'd like to share from what you've heard or from your own experience at HACT?
Thank you, Jeremy. Just a few thoughts. I mean, this has been a really fascinating conversation because in some respects, we've come at this question of social prescribing from a range of different angles. And I think what this shows for me is that actually this is a really vibrant and innovative and very exciting space to be in at the moment, even though it feels for many of us that we've been here before, or we've been doing this for a long time, and we're just seeing a new language or new concepts being kind of introduced into. But what that introduction is doing is it's bringing other people to the table. It's bringing other perspectives to the table. It's bringing other resources to the table. So I think actually the opportunity is in front of us. One of actually making connections where we haven't before, where we are finding new advocates in local neighbourhoods and local systems for this space, and also the opportunity to bring our whole organisations to that table. So we've heard people from different bits of a business and bits of housing talking about what they're doing, and in some respects, for many years within housing, sometimes the work that's been done by community investment teams and professionals, and the work done by tenant services, or the work done in care and support, or in sheltered housing, or in extra care housing, hasn't always felt like a joined up space in some respects. And I think that actually we've got an opportunity to become more joined up within our organisations. And then when we engage with people outside in the neighbourhoods and in the communities that we work, we have an opportunity to become joined up too. And we can bring our talents to that, we can bring our expertise, we can bring our resources, we can bring our physical assets, we can bring our social assets to that whole space. And then we can have another conversation, which is what is actually going on in our local neighbourhoods. How are people really being supported? Do we have the breadth and the depth of support that needs to be available to all different parts of our community? And how do we start to fill those gaps where perhaps we start to identify where perhaps there are certain types of services or certain types of support not really being fully delivered to certain groups of people? And I think that for me is actually where this whole agenda will probably and need to go in the future.
First Cardinal Sin, turn off your mic. That was great. And you may not have noticed in the chat that somebody put in interesting new housing minister. And I wasn't sure if they were referring to you in that short introduction about how you articulated your vision, but you certainly have set out a really ambitious call to action there. I'm going to come back to everybody in a moment. I just want to sort of pick up on a couple of the questions in the Q&A box. And one of them is from Sue Weston, and she sort of refers to some of the things back in the day about sort of how housing was commissioning support through supporting people and other initiatives. And she's really saying, do you think this would add value to the reliance on friends, relatives and neighbours for those with eligible needs? So I'm just wondering if you would, and she aims that at Ingrid to start off with. And Ingrid, I was wondering if you could start off by thinking a bit about that, and perhaps I can invite Emma and Janice to comment on that too.
Yeah, I saw that question, and I'll just preface by saying I know very little about this kind of commissioning for housing, and especially for people who don't meet the threshold. I think I would say that social prescribing is a whole community endeavour, and so it's hard. It won't work if budgets are siloed too much. So if there are some budgets that work for people in some types of housing and some for those who aren't, partly because everybody who lives in a neighbourhood uses the same kind of social infrastructure, like Sophie was laying out, the same kind of CAFs and the same bus shelters and the same kind of meanwhile spaces. And so it's about building the infrastructure for everybody. That doesn't mean that it's that budgets aren't siloed, they are. But I think one of the things that the new integrated care systems are intended to do is to create kind of place-based commissioning and kind of bring those things together. So that's kind of a bit of a wishy-washy answer because I'm not familiar with those particular budgets. But that's kind of my sense, that if social prescribing is going to work for the whole community, it needs to have a way of pooling budgets and pooling strategies together.
Emma, Janice, do you have any thoughts on this? I mean, dare I say supporting people Mark II, but it sounds like without supporting people, there's still mechanisms and approaches to think about how both people micro-commission services themselves, as well as relying on statutory funding. So any comments?
No, I don't have anything to add, Jeremy, to anything that you just said. I would have picked up on the things that you just said. I think the thing with the supporting people, what we miss is those social connections. And actually, when I think about the environment when we worked through supporting people, it was heavily based on the QAF, a set of criteria that we had to meet, that we have to evidence that we were actually delivering. And actually, it takes away from the actual individual and the person that is actually living in those environments, and we're not. That would be my worry.
Yeah.
Yes. Yeah, I agree. We look at our neighbourhoods as somewhere that everyone can live, and lots of people need access to different services, and those services aren't always there. But what we can do is, with collaborative working within the community, we can help those that need support if services aren't there for them, by building relationships between neighbours and communities. So, for instance, to combat loneliness and poor mental health, we will connect people that have activities and interests. So someone might have an interest in planting vegetables and growing vegetables on an allotment, but not a lot of time to oversee it. And there is someone down the road that would just love to do that, can't afford fresh vegetables, and by sort of helping on the allotment can also have fresh vegetables. So we're looking at different ways of supporting and collaboration within a community where some of the services that we really do need aren't necessarily there.
Sorry, who's that?
It's true. Might I just come? I mean, I thought I saw that comment, that thing from Sue as well, in the questions about supporting people, and of course I smiled to myself. Yes, it would be lovely to have the 80% of supporting people funding that's been taken out of the system back. It would have a huge impact, and have a huge impact on a lot of people. But I think actually what we're beginning to get to now is both that we're not going to get that back, but actually a reality that sometimes what we need is just a more coherent, connected space for people. The single point of contact is really important, so people don't have to keep on kind of washing around trying to find their way through what is a myriad of different types of support in a local area. But also not forgetting that housing associations often commission services as well, particularly in the community investment space and other spaces. So how do we do that better, and how do we utilise the assets locally to be able to provide that kind of support to people who are living in the homes that we manage? And I think that is the question that is probably more within our grasp than government refunding local government for all the money that's been taken away.
Thanks, Drew. I'm sorry. I had the Q&A box open, so it covered your face there. But unfortunately, Tony, I was going to come to Tony's question next. Tony's actually a resident and trustee of Brunel Care, a southwest-based housing association in Bristol, from memory. And he was talking about some of the old sort of role of the resident warden, and sort of that, who knew the tenants. And again, Janice, you talked about that trust, and I think, Emma, you also talked about those relationships around in those types of communities. Are any sort of issues that you think have changed over the last 10, 15 years, sort of in terms of how we can support residents, in addition to the coaching and mentoring that you've described?
Sorry, I saw Tony's comment as well, and I smiled because I remembered a time when we did have residential scheme managers living in all of our on all of our sites, and to a certain extent, Tony's right. Actually, you know, it is about that resident scheme manager would have actually built the relationships with the residents, with their family members. But actually, what's got harder over time and why our models have changed is because, you know, as a society we've changed. People don't want those roles anymore. They don't want to live in those don't want to live on the doorstep anymore. They want to actually, a lot of those spaces weren't big enough for family homes, and so they want to live where they've got the bigger space. So yes, I agree with Tony to a certain extent, but actually we've got to evolve with what we've got.
Yeah, Jeremy, you've got your hand up.
I was just going to add, I was thinking about Tony's comment, and one of the things we want to explore in this programme is the role of volunteers, and how do we support the development of community-based volunteers alongside the paid staff, because there's some really interesting examples where some of the housing associations I've been talking to have done that brilliantly. So I just wanted to flag that as one opportunity that I think we should be exploring. The other thing I was going to comment on, I love Janice's comment right at the beginning, and it hasn't really been picked up, is just the importance of language. Just changing the name from housing warden or housing officer to neighbour, you know, to language that's more inclusive. And I think often we fall at the first hurdle by using language that makes us feel distant from people rather than connected to them. And I thought your example was a great example, Janice, of how to change that.
Thank you.
Yeah, and I thought that also followed on neatly with what Richard was saying about how do we change culture and behaviour, and some of that will be language, some will be about raising awareness. Now, Richard, I know you've been answering some of the questions in the chat box and in the Q&A box. There was one earlier around sort of the construction industry and how engaged are they? I think it was the question. Any comments on that?
Well, we're kind of we're still early stages, so we're piloting and developing our relationship with North London NHS, and once we've done that, we're going to speak to the Construction Leadership Council and some of the other organisations where we've got contacts. I sense that there is a genuine appetite for health and well-being, but it is a very difficult area for contractual organisations to engage with, and we're thinking about a project that we've provisionally titled Health Positive, which is actually about trying to create a single communication channel for all of the different health and well-being organisations, a communication channel that works in both directions, so we can send information out to the industry. They sign up to one communication channel and they get a broad range of advice and support and linkages, and also that can work the other way in terms of organisations feeding into improvements in industry practice. So it's early stages. It's desperately needed, I think, and the industry has woken up to the fact that its workforce is shrinking rapidly and that it has to value its people more. So, you know, we can only push on and try to forge those connections and find kind of creative ways of linking things. And I think the critical thing is very, and this is why I'm intrigued by the idea of a social prescribing network for the construction sector, because there is a lot of help and support out there, but people cannot find it. They find it so difficult to actually kind of come into interactions with the available support networks and ways that they can address their issues. So how engaged are they? I will report back. I'll come back in a year and tell everyone if they're interested.
Well, I'm sure it's also a conversation that Ingrid and Jeremy and the team at NASP would be welcome to have a conversation with you about how to take that forward. And as Ingrid highlighted in her opening remarks, you know, the idea being that today is really about a taster, and then there are a few more webinars that are now taking place. So please do sign up to join those and participate in those. Sophie, final question to you. You've heard a lot of the evidence. You talked about some of the work that Irving Goffman about inattention, you know, and I thought that was a really good phrase. Are there any other sort of hot tips that you think that we can learn from our housing sector about that social architecture and that social infrastructure, perhaps to invert that triangle so that the people are at the top, you know, as part of that social prescription triangle?
Yeah, I think, I mean, in the book, I don't cover literature on social housing providers or housing providers per se, but obviously what struck me throughout the conversation is the huge role that social housing providers have in the communities, and perhaps the kind of lobbying role that these organisations can have in kind of, you know, pushing back when, you know, you've had the example from Emma of the bus stop and the seating being provided in it, kind of just a really small fix that made a huge, or would have made a huge impact, I'm sure, on the people using those spaces. So thinking about, you know, I think a lot of these conversations kind of go quite wide in terms of urban planning and kind of, you know, how we plan our communities and how we prioritize the spaces in our communities. And I think there's a role of social housing providers there and kind of thinking about the kind of spaces that are worth saving and listening to residents about what are the important spaces to them and where people are having their social interactions, as we've heard about meeting people where they are and making sure that those spaces that are important in communities are preserved or kind of enhanced or protected or made more accessible in some ways, I think. So I think there's a huge role there in kind of using that kind of role that social housing providers have to take that holistic view, I think.
Well, look, I'm conscious we've hit 5:15 and I know several people have already had to leave slightly prematurely. On behalf of the HousingLIN, can I thank you all for all your excellent contributions? Can I also remind you, if you are interested in this, a number of really helpful reports have been posted in the chat box. We will share those along with the recording and the slides during this week. Can I also just draw attention, you know, we are running a series of happy hours, and in fact our next one on the 22nd of February touches on the levelling up agenda, very much part of what Jeremy sort of highlighted in his opening remarks, and the call for that national task force and how different organisations are responding. But if you are sort of stimulated by any of the issues that have been presented this afternoon, please do share those with us. Please do sign up for the ongoing webinars that NASP are running and ourselves, and do let us know if there's any way that we can support or help you connect both the policies, the ideas and the resources that are available. Can I thank everybody once again for your contribution, and for those of you who are attending as delegates, there will be an invitation for you to just complete a short questionnaire to give us your feedback. We do welcome that, and hopefully that will help inform and influence our future sessions. So can I thank you and the team behind the scenes for all your help. Thanks again. Bye everybody.